Welcome everyone to today's program. I am Kathy Brett with Becker's Healthcare. The program will begin with a presentation followed by a question and answer session after the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenter will attempt to answer as many questions as she can during the time we have and will follow up on questions she does not have the opportunity to address. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email immediately after today's program, and you can submit your feedback or any additional questions at that time. And that email will not include the presentation. It is now my pleasure to introduce today's presenter. Angela Talton joined National Medical Billing Services in 2012 as Senior Vice President of Coding. She leads the company's coding and compliance departments, providing the long-term planning and operational oversight. Angela is also responsible for planning and managing the strategic integration of regulatory changes such as ICD-10 at the corporate level and ensuring all national medical coders are properly trained. Currently, Angela is the president of Eastern Missouri Health Information Management Association. During her tenure, this chapter was recognized by the state organization MOHEMA as the model association to seek for innovation in providing coding education to members. Angela is also an AHIMA-approved ICD-10 certified trainer. Angela earned a bachelor's degree in Health Information Administration from Stephens College in Columbia, Missouri, and a bachelor's degree in Business Administration, Management Organizational Behavior from the University of Missouri, St. Louis. She also earned an MBA from Lindenwood University in St. Charles, Missouri. It is now my pleasure to turn the floor over to Angela to begin today's presentation.
Thank you, Kathy. Today's topic, where ASCs should be with ICD-10, is really going to resonate with the organizational challenges overall and the greater picture that we need to look forward to as the transition takes place. Next slide. To introduce what we're going to go over today, the transition to ICD-10 in October 1st, 2014 will be a defining moment in the healthcare overall for the United States. The healthcare clinicians and the professionals will determine their success on how well they are prepared. The physicians must be prepared for this change or risk a horrific reduction in reimbursement. Next slide. The objectives that we like to focus on is going to understand the history of ICD-10 and grasp the general knowledge of the ICD-10 overview as it relates to the GEMS maxi and the basic makeup. We're also going to walk through the implementation process and the steps that we need to take in order to be successful and ready for ICD-10. And then we'll look at a glimpse of what can happen if we're not prepared. Next slide. Next slide. The history of ICD-10, it was created by the World Health Organization in 1994, with the first country implementing ICD-10 in 1995, and the last country implemented in 2002. The reason that we're going to look at ICD-10 as a focus is because the United States has been on ICD-9 for over 30 years. While the countries overall that we see here, they're preparing for ICD-11, it would be a huge learning curve and a huge undertaking to jump from ICD-9 to ICD-11. With that said, we're going to focus on what our organizations need to do to prepare for ICD-10. Next slide. So why the need? ICD-10 is outdated, first of all, with the number of limited abilities to expand that code set. So it doesn't account for all the new technology and or the specific in code sets. With that being said, the specificity needed for a number of emerging uses for pay-for-services and biosurveillance, it can't grow in ICD-9. So as technology grows, we have to have a code set that will allow medicine and technology to meet together. Next slide. ICD-10 doesn't really have the exactness for the DRGs if you are a healthcare facility or acute care facility that is very different for reimbursement. It also lacks the specificity and detail for which is inconsistent. We can't capture the new technology, and it also lacks the code for preventative services. And ultimately, sooner or later, ICD-9 will run out of space, and it will mainly affect the procedure code. Next slide. Healthcare transactions also requires the claims, prescriptions, procedures, and all other healthcare transactions to be compliant as well. So we'll take a glimpse at what we need to do in order to prepare for the I-9 transition to I-10. Healthcare transactions that are processed through IT systems and most utilize specific codes to identify the diagnosis and procedure codes will have to have a huge overhaul in order to prepare for I-10. Next slide. So who's affected by ICD-10? Essentially, everyone that falls under the HIPAA Health Insurance Portability and Accountability Act will be affected, not just those who's submitting Medicare claims. The change for ICD-10 does not affect the CPT codes for outpatient procedures. And on slide 9, we'll take a look at the landscape for how we need to prepare. Starting with the physicians, the documentation for reimbursements for services provided is really going to be the pivotal point for physicians. This is going to be their largest learning curve yet. The code set is going to be a smaller scale. The level of specificity and granularity is really going to take place in the culture change in the physician realm. The clinical area, the Superbills are going to have to be revised, considered to adjust for those codes that will be implemented as a result of ICD-10. The ABNs, as well as the LCDs, the NCDs, will have to take a peek at how you need to change those as it relates to the ICD-10 change. The front desk area will have to consider all of their HIPAA and privacy policies, modify those as needed, and maybe even look at the systems overall. The code set is going to be the next huge undertaking. Right now, we're looking at 17,000 codes, but as a result of ICD-10, we are growing towards 140,000 new codes, and that set is continually growing. The clinical knowledge is going to have to be more exact. The anatomy and physiology piece for coders will have to be beefed up. If the coders aren't familiar with the A&P side of it, refresher courses may be involved. And then the concurrent use of dual coding in I-9 and I-10 is going to get the coders more prepared and well prepared for the transition. For the billing office, the policies and procedures may consider looking at those policies to update the changes and the workflows that will be affected as a result of ICD-10. And lastly, the nurses in the labs, documentation is going to be important as well as reporting in other forms. Next slide. So what is the ICD-10 implementation? Well, it's a process of changing clinical documentation, any billing practices, and payment structures, and the IT infrastructure to accept the codes for ICD-10 as part of being compliant. it'll require a thorough overhaul of the IT systems, the physician documentation, and even the coding procedures. On slide 11, we're going to look at what's the best approach. The industry standard is stating that it's always a good idea to look at ICD-10 and approach it from phases. The big thing, go live, is really a harder way to go as it relates to finding ineffective processes, systems, work stoppages, and other breakdowns that can result as a big bang theory. So working this implementation in steps will be the best and recommended way to go. The plan will provide an outlook as an overall picture of where you need to improve your processes in order to gear up for ICD-10. On our next slide, we'll show and illustrate the timeline for where we need to be as of today as it relates to the ICD-10 implementation. I want to caution you, you're at least a year behind if you've not established the steering committee, a physician champion, or the ICD-10 project manager. That should have been developed early part of first quarter or third quarter in 2012. If you're not looking at what your staff needs in terms of training, convert your contracts, your physician documentation. If you're not working with your providers to improve their documentation for Joint Commission standards as it relates to H&Ps, operative reports, or procedure notes. And then look at your EMR systems or your EHR systems to see the capabilities that they have to receive those codes for ICD-10. So as of today, the third quarter, we should have accomplished at least 4 major steps as it relates to the implementation process. And then finally, looking ahead in year 2014, the preparation for go live and continue with physician education and education overall. And then what are your plans for training, the post-go live training, and your countdown, your 90, 60, 30 days to go live. Next slide. So how do we plan for ICD-10? In phase 1, forming a steering committee is first and foremost, getting the key stakeholders together, understand what the goals are for the organization in order to roll out ICD-10 and be successful. The decision makers will include a physician champion, an IT leadership person, usually the CIO or the director of IT, the ICD-10 project manager, the person that's kind of overseeing the activities completed for the ICD-10 implementation process, reporting back to that person and understanding and alerting where barriers exist. The coding leadership is also important. Managers and above, they're always recommended. The financial leadership realm, the CFO, the CPA directors and managers are also important, as well as the other rev cycle leaders. These folks here will have to have a hand in developing and approving any budget that is considered for the ICD-10 project. On slide 14, we want to look at how do we do that. Well, first off, the steering committee's goals and initiatives is to create a culture of embracing ICD-10. Negative Nancy cannot exist in this piece of the puzzle. We have to have all creative hands on deck. We also need to include innovation ideas, people that are on board and will express and communicate those changes as it relates to ICD-10 on a strategic and employee level. Also position operationally what challenge and identify what the opportunities are at the strategic level. Really look at what is most vulnerable to being a defect or a deficiency, if you will, for ICD-10. Conduct an environmental scan. Just look at your landscape as an organization. Look through any operational dysfunction area and see what we can do to improve it. And identify ways to incorporate an analytical project. Will this change affect ICD-10 be positive, or should we keep the process as it is, or should we just not have this process incorporated with our new change overall? Finally, develop and or use a risk assessment tool to track your progress. Next slide. So here's what you can consider when you're performing a risk assessment. Identify the risk and then rank them in order of importance. What's the easiest to take care of first? What is that's going to be more involved? What do we need to do in order to step by step take a look at the processes and or identify what's going to take a little bit longer versus what can be completed right away? Identify the triggers. Why is this occurring in the first place? What do we need to do to change our landscape? What can we improve on our policies and procedures? And also develop a contingency plan. Develop a plan where you want to go with first, but also have that backup plan just in case your first initial thoughts aren't where they should be as far as the transition. And then have enough resources. Document the progress as you go along with your steps. Next slide. The budget piece for ICD-10 is very, very, very important. Things to consider when you're developing your budget will be the process improvement piece, system upgrades and testing, and staff training. All of those encompasses with that budget transformation and that budget consideration as it relates to ICD-10. Next slide. To be very frank, the ICD-10 transition is going to be very expensive for some organizations. Not just for a small practice, but the accountability will be shared through ASCs overall. So each functional area has to have an accountable action plan and be considered within the budget. It's recommended that the ASCs reserve 2 to 3 months of revenue and or consider a line of credit for the first few months post-go live. This is a huge, huge recommendation from CMS. While we plan to make sure that we are ready for go live, we want to be prepared on the back end just in case we have to fix some inefficiencies post-go live. So this is a huge recommendation from CMS. Next slide. Other things and other areas of the organization to consider are the software upgrades, contract modifications, the vendor fees, the change management, and additional staff. If you have to have additional staff to adjust for any backlogs and or overhaul within any functional area, you want to make sure that that budget reflects that opportunity. Training is also important, and any wrap-up work that you will have to take care of post-go live. Next slide. One thing to mention about the contract is that for each facility, you might want to look at your contracts as you go through this transition, as the relationship and the language may change as a result of ICD-10. So contracts may not be affected, but it is worth looking at those contracts along the way. Next slide. And here's a warning. If your organization hasn't established the following, you're severely behind in the planning stage. If you haven't established that steering committee and a budget, identified those system specifications, requested proposals from the software vendors, identified training needs for end users, or the physician champions and super users and each functional area subject matter experts, you're really behind. In slide 21, What do we need to do in order to play catch-up? At this point in time, we'll have to have all available subject matter experts on deck, including the project planning folks, the budget establishment, and the request for proposals. This phase here at the end of the pyramid will likely overlap with the needs assessment intake. So this can require 2 to 5 major key people here in the decision-making process to establish where we need to go for ICD-10. For the IT piece, we will need an additional 2 to 3 people there. So we're up to at least 5 people, 5 to 6 people, just try to get us back on track with the GEMS mapping, the technology improvement, and the ICD-10 special project group, that analytical project that we talked about, and contacting our vendors with time constraints. So if you have to have additional staff, this is the time to consider that. And by December 31st, 2013, you really should be in training mode. Next slide. In phase 2, the initiatives are to encourage your teams and department project leaders to work together and get the employees involved. Have a sense of ownership with the employees and have them share that action plan process. Have them be a part of that decision making for work that's going to affect their realm as it relates to ICD-10. Make it very real to the employees. Have them look at the process as it exists and have them develop that process or action planning just to make sure that they are considering and the leaders are considering everything, every step, every detail of that department so that ICD-10 can be successful. Next slide. The first step is to perform a departmental needs assessment. And this is really a pulse check of what's going well within the department and what tools and resources your employees will need in order to make sure that this transition is smooth. If they don't have the resources, consider those for budgetary considerations, and also make sure that the work groups consider every policy and procedure as it relates to ICD-10 and how that will affect the change. Next slide. The process of collecting this data and analyzing it is about 30 days. You want to make sure you're giving a full circle thought of what's going on within each functional area. You don't want to leave out an opportunity to capitalize on ways to change the department to improve the processes, to update policies and procedures in order to get ready for ICD-10. After the data has been collected, you want to analyze it, and this shouldn't take more than a week. But you want to make sure that it's communicated to your senior leaders within a timely fashion and use a formal report. It's not enough to communicate it verbally, but you want to document your process overall. Next slide. The functional area process improvement. Here are some questions to consider. It is not conclusive to all the questions that you need to consider, but just a thought. Will the process be slower as a result of the new technology as it relates to ICD-10? Will a learning curve exist? How well prepared are our employees? Will there be a quality check to ensure accuracy? If so, is the quality check that we have in place right now, will that work for ICD-10? Or what things do we need to consider in order to beef up for that transition? And also look at your policies and procedures and consider updating those to adjust for that change as well. Workflows are likely to change, so look at what's going on today and how will it change or how will it look after ICD-10. Next slide. So here's the hub for how ICD-10 will change the organization overall. The clinical documentation piece will really be the challenge. Without the documentation, all other functional areas can be affected. Talking to your providers of service, mid-level doctors, on ways to improve their documentation will lead to greater success. Next slide. Here are the goals for the physicians. Look and identify the trends for the doctors that are having missing information, conflicting or ambiguous documentation that will slow down the coding process. If there are queries being sent to one provider over other, you want to make sure that you're having a conversation with that doctor in order to improve the documentation. Make sure that the physician knows that the Joint Commission standards for operative notes, the H&Ps and discharge summaries or procedure reports really have to be addressed in each and every encounter 100% of the time. Make sure that you also mention the supporting of the accurate diagnostic and procedural coding. And we don't want to overcode or undercode, but we want to code exactly what the provider has performed as far as that service is concerned. We want to improve the communications between the coders and the providers overall. We want to have that open dialogue and foster that positive relationship and create an environment for education. And ultimately, that'll lead to better documentation, and that will reflect for quality and outcome scores that will be higher. And the providers will also like that as well. The key CDI metrics to consider are who's being queried most often? What's the volume of your queries? Is it the same provider? Are there a couple of providers? And will this affect patient care? We want to be as specific as we can be in the documentation area for ICD-10 in order to illustrate the services that were performed. It will also improve the case mix index as it relates to data and trending and reporting as for that matter. Also, the documentation habits will change as a result of the continual education for the providers. Next slide. Here's the values for ICD-10. The physicians will see patients and write the notes in a template that's geared towards that encounter. So 100% of the time, all the elements of the notes will be addressed. It's signed, timed, and dated in a timely fashion. The EHRs will remind the doctors of the key elements that they have to address. So consider in this area putting hard stops in certain areas of the EMRs or the EHRs so that the doctor can address those issues. The coders will be able to apply a code in a timely fashion and bill out that particular encounter without delay. And then ultimately, the doctors will be less likely to be queried because the documentation is well documented and it is complete. And that's a win-win for everyone. Also consider working with your vendors as far as this implementation process is concerned. Understand what your vendor's plans are for ICD-10. If you work with more than one vendor, check out the landscape of what they are doing now to prepare, if they've started, if they've not started. If they haven't started planning for ICD-10, ask when do they plan to do so. And if they haven't have a plan or they don't have a date in mind, consider a request for a proposal from other vendors as your contingency plan. You want to be well prepared and you want your vendors to be ready to adhere to the timeline that you set for your organization as it relates to ASCs as well. In phase 3, you really want to focus on that training opportunities for all functional areas of the organization. Coding staff is really going to have that next greatest impact as it relates to ICD-10, with the code sets not being a 1-to-1 ratio, they're going to have a decision-making time period that's going to take slightly longer than assigning a code from I-9. I-10 is very detailed. For the IT personnel, you want to consider those training sessions as it relates to the GEMS mapping, and you want to also consider the legacy data. How are you going to house those for those folks? And the business associates also need to consider the vendors, the payers, and other data users just to make sure that new business agreements are signed if needed. Next slide. Here are some of the industry recommendations for the basic training. This is just the basic background knowledge of what ICD-10 will entail. How to find a code can take 6 hours. And that basic overview, just the high-level overview, can take anywhere from 1 to 2 hours. How to document an ICD-10. The clinical staff, the nurses, can take up to 6 hours. The physicians and non-physicians, the mid-level, can take anywhere from 20 to more hours based on the documentation as it exists today. The ICD-10 coding for coders, how to find the code, how to apply the code, the direct application of the codes can take up to 40 hours. And the analytics piece can take up to 6 hours, and that's just at minimum. But it is always recommended that you consider more extensive training throughout this process, throughout this time from today to October 1st, 2014. Next slide. So here's the landscape for ICD-10. As it relates to ICD-9, we have the etiology, the anatomic site, and the manifestation codes that will still exist from I-9 and 10. But what's different about the codes for ICD-10 is that the extension piece will allow that diagnosis code to grow. As technology advances, that placeholder that will occupy by letter X can potentially turn into a full 7-digit code. That's the beauty for ICD-10. The initial encounter, the subsequent encounter, and the sequela encounter will be new terminology for ICD-10 over ICD-9. And that's also known as the episode of care. So for the coders, they will have to learn a different language for ICD-10. And speaking of the coding, you want to actually look at their strengths. Are they good at AMP? Do they need an AMP refresher? Do we need to look at surgical devices? Do we have to look at medical terminology? Where are your strengths right now as it relates to ICD-10? And keep it viable in your meetings. Have a scavenger hunt for ICD-10 codes. Have a one-on-one conversation with your coders. And also have the coders apply those ICD-10 codes to I-9 procedures. Redacted operative notes is always a good idea, so the coders can get used to applying those codes. And also time them on how long it takes them to complete just that one operative report. Dual coding is going to be very important for ICD-10. Coders need to get used to coding in I-9 and I-10 as quickly as possible. Industry standards, they're really considering starting now if you haven't, but definitely by the beginning of the year you need to have that thought in place. Have your coders as quickly as possible engage in dual coding. We're going to have that for statistical purposes as well as reporting. So you want to make sure that they are comfortable in both realms of code sets. The granularity provides the greater level of detail with the diagnosis selection, and the laterality provides the level of specificity. Left, right is an example of laterality. Next slide. I want to focus on step 5 for the coders. According to AAPC, it's recommended that a 75-question unproctored test will be required to maintain the credentials. You have approximately October 1st, 2013 to September of 2015 to take this test in order to keep your credentials. So it's this organization that owns those CPC, CPC-H credentials are really methodic about learning this new code set. So you want to be very, very careful to make sure that you are well aware and well prepared for that transition if you are a coder. Next slide. Next slide. For the IT piece, these 2 columns should have been completed at this time. Most importantly, if we have identified the business areas for the transition completed in phase 1, we wanted to make sure that the IT professionals are educated on the regulatory changes, identify new hardware and software requirements, identify the system interfaces and capabilities as it relates to ICD-10. GEMS mapping training for the professional data conversion, the system implementation, and how the legacy data will be housed. We want to make sure that we consider all areas of an organization as it relates to ASCs to be well prepared, and the IT piece will be very important during that transition. Next slide. System testing. This should be a continual process. Prior to October 1st, 2014, we should have been doing this early part of this year, if not sooner. Making system modifications as needed, test often, and it is recommended that you test once per month, once per week, over once per quarter. The regression testing is going to be important as well. Determine the level of support. Are you going to have an AM, PM staff for IT? How are the employees going to work as the transition? Are you going to work around the clock? How much IT support will the employees need according to their schedule? The Superbill updates is going to be important as well. Are you going to house all of the codes on the Superbill, or the codes only related to the encounters that the patient has? Ensure that the GEMS mapping has the bidirectional receivement, or to receive the codes bidirectionally from I-9 to I-10. If it comes out of one system, it has to be able to go back in. Let's look at the vendor readiness. Test with your vendors, and this is also going to be encompassed with that IT support. Look at what their landscapes are and the trading partners. Work with your EDI folks. Make sure that they have a plan for ICD-10 as well. Establish a contact person. That's going to be the key here. You want to make sure that you have a good contact person to get regular updates and to trend any opportunities for improvement and any milestones as it relates to this transition. You want to develop monthly meetings with the team, and you want to make sure that you document the process as well. You want to look at any process delays, and you want to also look at the progress overall. The system progress is going to really affect the opportunity to be well prepared for ICD-10. And just looking at the landscape for 5010, we've already come and gone on the January 1st, 2012 implementation date. But let's consider the ICD-10 cutover. What are you doing within the ASCs to make sure that you are ready for that date? Will you house that legacy system? Will you keep most of the data on one server? Will you need multiple servers? Will you take ICD-10 from day one? Will you pull in data from another system? Or will you just have two separate systems and house them that way? Next slide. In phase 4, you want to make sure that everybody's coming back as a group and talk about the progress that's been made. Again, those senior executives, the coding leadership, the IT leadership, the financial management folks, the physician champion, and the other key stakeholders. Get them back onto the same page with that project leader to say, within 5 months, we were able to accomplish 10 goals. We still have 15 left, and here's how we plan to accomplish them. There was one barrier, but we've identified the risk, and we are moving forward with our plan. We want to make sure that there are regular conversations with the folks that are supporting the transition, and we want to make sure that we're communicating with them regularly. We want to also update the project plan as needed. If you have an overall project, look at it every week. The project leader will direct the staff on where they need to change, what value-added initiatives they have, and what things are at risk. You need to modify and change the budget. Did you over-budget for one particular department? Did you under-budget for another? We want to make sure we have that room for growth just in case there was some unforeseen financial risk that we did consider for a department, that we have that resource to cover any breakdowns within the processes. We want to develop and implement a communication plan. And that plan will also include a rollout on how you want to communicate to the employees. Each functional area will have a different plan, but you want to make sure that it's communicated in a consistent manner. Excuse me. That consistent management style is going to be key. That consistent management style will really need to be focal on how the key leadership wants that communication plan to be rolled out. Continuing the staff training. That staff training is going to be important. That just-in-time training is going to be very, very important, and I can't stress that enough. It's not enough to train your staff 6 months before the implementation, a year before the implementation. It has to be relevant to the work that they do. It is strongly considered or recommended that you apply the ICD-10 methodologies within your staff meetings, in your stand-ups, your huddles, or whatever communication mode that you have for your functional area in order to keep it viable. So why is planning important? Well, the insurance companies are anticipating that organizations and providers aren't going to be prepared for ICD-10. So they want to capitalize on the denials. The claim errors will increase because level of specificity will not be realized as a claim comes through. The insurance companies are planning to narrow the timely filing and a timely follow-up limit. And in that, we have right now as long as 180 days or as small as 30 days. Well, with the implementation for ICD-10s, it's been spoke of that the providers will have a 45 to 15-day turnaround time. So by the time that claim suspends in the insurance company system and then it rejects out, there's mail time if there's not an electronic way of communicating to the provider of a denial. By that time, the time could lapse and that claim is totally denied. So we really want to make sure that ASCs are well prepared for that transition to mitigate any risk of denials. Next slide. Just to reiterate the potential risk. If we authorize the wrong diagnosis code, that will cause a coding backlog because there's not going to be timely submission of the information to the coding department. Well, the coders will assign an incomplete or a nonspecific code, which will lead to improper claims payments or a rejection. But overall, the decrease in reimbursement is going to be the ultimate detriment. Next slide. This is going to be a very huge undertaking as it relates to productivity. For smaller practices, 76% of the expenditures is going to make up that productivity loss, but it can increase to 89% for large practices. And this is according to CMS as well. We really have to consider the budgetary cushion for the reduction in productivity. The learning curve for ICD-10 can be great, or it can be as narrow as long as the organization is well prepared. It's going to be so dependent on your ability to get the organization marching to the same beat, the same tune, as it relates to this ICD-10 implementation. Next slide. So in summary, let's consider breaking down ICD-10 into workable pieces and create that buy-in environment. Negative Nancy cannot exist at this point in time for any ASC facilities or any organization. We have to incorporate the ICD-10 conversations into team meetings. They have to consider, live, eat, and sleep these ICD-10 transitional efforts. But we need to look for ways to continually improve processes within the rev cycle overall. If we refine a process, look at it again. Make sure we're not omitting or not considering things that we haven't thought of the first time or even the second time. Third over is not a bad idea as we're trying to get well prepared. And this is ultimately going to mitigate or reduce the financial risk because you will be better prepared. And at this time, we have a little bit of time left, about 13 minutes for questions.
Okay, well, thank you, Angela, for a very informative and enjoyable presentation. And we can now begin the Q&A. As a reminder to the attendees, you can submit your questions that you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. And Angela will attempt to answer as many questions as we can during the time we have. I do see that we have a few questions coming in. And so if I may, Angela, earlier your slide said this did not affect ASCs, but now you say we need to be prepared too. Are you saying if the doctors are not prepared, it will affect our revenue collections? We don't really have to do anything different as an ASC, is that right?
The facility overall, no, but how it will tie back into the ANC is the documentation. For the providers that perform services within the ASCs, they have to really look at their documentation to make sure that their procedure notes contains all the elements of an operative report, an H&P, or an office visit to ensure that the impact for the reimbursement reduction is not affected.
Okay, well, thank you. Another question I have here for you is, where would you recommend ICD-10 training? For what company?
There are a number of companies that can offer the same training. The organization will have to consider time out of the office. They're going to have to consider if on-site training is the best solution. The recommendation is to look at the landscape to see how will an off-site meeting affect productivity. Will it be beneficial to have the on-site training or after-hours training? Online training is also a consideration. It just is totally dependent upon the organization.
Okay, great, thank you. Will October 1st, 2014 be pushed back, and is the October 1st deadline for dates of service?
October 1st, 2014 is a hard date. CMS has confirmed that some time ago. And it is, regardless of date of service, October 1st, any patient with services submitted, for example, date of service September 30th, but it's not submitted until October 1st, will have to have the ICD-10 codes applied. It's regardless of date of service.
Okay, thank you. In all of the ICD-10 webinars, this attendee asks, in all of the ICD-10 webinars I have attended, none of them have specified anything to do with the mental health clinicians being affected. Won't this affect the mental health side as well?
As it relates to the diagnosis codes, it absolutely will. The same preparation, looking at the landscape of the operations is going to be important. The documentation and definitely the procedure codes, the PCS portion of mental health, and diagnosis codes will be affected.
Okay, thank you, Angela. Another question I have here is, should I have my coder trained in ICD-10?
Absolutely. That's going to be the second biggest change for ICD-10. If the coders aren't trained and there's not a mapping process in place at the organization, that coder will not be able to adjust to the impact of the change. We're growing from 17,000 codes to approximately 140,000, and it's growing every year. That coder will not be able to submit a level of specificity for the services provided if they're not exposed to that coding.
Okay, thank you. What about workers' compensation claims? Will they be using ICD-10?
You have to use dual coding, I-9 and I-10, but moreover, the I-9 codes will get them ready for I-10, but they have to participate in the dual coding.
Okay, great. Thank you. I just wanted to draw the attendees' attention to the last slide you see on your screen here. If you want to contact Angela or NMBS, the information, it would be info@nationalascbilling.com, and you can send your questions or comments to her using this email address you see up here on your screen. I believe we do have a couple of more questions coming in. I don't know if we have time to take these. I'll ask Adina on our side if she wanted to take these last couple, or should we wrap it up?
Hey, Kathy, it's Angela. I just want to make a clarification on the workman's comp. Depending on whether or not that particular carrier wants to accept I-9 and I-10, we have to make sure that we're participating in that dual coding. But workman's comp is exempt from the transition. So that carrier may or may not want that.
Okay, great. Thank you. It does clarify. We do have time for one more question. We recently attended a AAPC conference and were instructed by a Novitas rep that claims must reflect diagnosis codes according to the date of service, not date of submission. Please let us know where we can reference this.
If you go to CMS's website, it clearly states it's that hard date, regardless of dates of service. So I recommend that listener to go to CMS's website.
Okay, thank you. Angela, I want to thank you again for your excellent presentation today and for all of you who participated in today's webinar. We look forward to having you join us for future webinars. This will conclude today's program, and have a wonderful afternoon.
Thank you.